Good morning and welcome to the 2024 Arizona Cancer Registry Annual Educational Workshop. I'm Juliette Wilkins. I'm the Training and Policy Manager for the Arizona Cancer Registry, and I've just got a few housekeeping items to go over before we get started with today's session. Thank you all so much for joining us for this education. So first, one change that we've had since we met last year is that we are now under the Division of Policy and Intergovernmental Affairs. And you can see that we also fit with vital records. We've worked very closely with them before, and tribal and county health liaisons are also part of policy and intergovernmental affairs, as well as media relations and communications. So that is our new home. And for those of you who have not attended one of these sessions before, I'd just like to go through really quickly who your Arizona Cancer Registry team is, so that when you interact with us, you've got an idea of who we are and what we do. We have an operations section, and that is helmed by Rayanne Robinson, who's the section manager. And with Rayanne is her operations team, and that is Sarah Yeager, Mike Raymond, and new to us is Jordan Burge. And so welcome, Jordan, to the ACR. They cover data processing, quality control, editing, tracking, and data collection from our hospital registries, from our clinics, our physicians' offices, pathology laboratories, and from our other data sources. And they do excellent work in the operations section. Then there's the quality assurance section, and that is headed by Michelle Lenzen, our QA manager. And her job involves QA studies, audits, and the death clearance process. And then there's training, and that's my section. I'm Juliette Wilkins, and I'm responsible for internal and external training, documentation of any of our internal ACR policies, and our user manual, our ACR handbook that we put out every year for you to know what the coding changes are. And then there's the data section, and that is led by Dana Doyle, our epidemiologist, and you're going to hear from her shortly. And Dana works on data analysis, report writing, and cancer concerns, and also does excellent presentations. So I'm excited to hear what she has to say in just a little bit. And then we also have a senior program analyst position, which is currently vacant, but that position covers electronic reporting and linkages and the back-end programming side of what we do. So that is your Arizona Cancer Registry team. I did just find out this morning, I'm very excited about this, that we've been approved for 8 CE hours by NCRA, and 3 of those are designated Category A CE hours. And you see our event number there. After this meeting, I will be sending out a CE tracker so you can keep track of which sessions you attended. And that will tell you how many CE hours you earn for each session. Because as you know, we are going to have 4 separate sessions this year on different days. So you can claim CE credit based on which sessions you attend. And after session 4, you will be emailed a certificate of completion. And we are also going to make available to you an evaluation form for this morning's session. That's going to be in the chat in just a few minutes. And we do encourage you to fill out that evaluation. We really do want your feedback on what education you would like to see from us in coming sessions and what worked really well, and give us some suggestions for next year. So look for that in the chat shortly. So today, after my welcome presentation, which we are doing right now, Georgia is going to give us some updates and our Arizona Cancer Registry overview for the year, what we're focusing on, and give you some good information on where we're going as a central registry. And then Dana, our epidemiologist, is going to talk about Arizona's cancer burden and the Arizona Cancer Registry data usage and how the patient data that you collect actually gets used in clinical settings and in epidemiology. And then she's going to be followed by Cassandra Webb, who is with the Arizona Cancer Coalition, and she's going to review with us the new 5-year Arizona Cancer Control Plan. And then we'll have our formal Q&A session at the end of today's workshop. Then our next session is not next week because that's the SEER workshop, but we'll be meeting again on October 3rd, same time. And you can see that we're going to be talking about lung and esophagus abstracting. And that's going to be a combined presentation between Dana, myself, and Dr. Peter Bayek, who is with City of Hope. He's a thoracic surgeon, and he's going to review with us the anatomy and treatment and staging of lung and esophageal cancer. And I'm very excited to see what he has to present to us. And then session 3 is going to be October 10th, same time. We'll be talking about 2024 data collection changes. I'll be giving a presentation on grade because I know that that is challenging to code the correct grade when we're abstracting. And then Michelle is going to be giving a presentation on current quality assurance projects and updates from the QA manager perspective. And then our 4th session is going to be October 17th. And we'll be hearing from Rayanne Robinson, our operations manager, and she'll be giving us an update on what's going on with the operations team and also Webb Plus and how we're using that CDC software to capture our cancer data. And then I will be doing our second site-specific abstracting presentation, and I'm covering prostate this year. So that is the big picture overview of what this workshop is going to contain. We hope that you'll join us for all 4 of those sessions. We've got 2 separate chats for you. You'll see at the bottom of your screen that we have a chat which you can use for general questions and comments, for communicating with one another and with technical questions. Please be respectful and professional and thoughtful in your comments in the chat because they will be viewable to the rest of the attendees. And then we've also got a Q&A chat, which is specifically for questions related to the sessions. We'll be answering questions from all the presentations today at the end during the formal Q&A time, so please be as specific as possible with your questions. Any questions we don't get to during the live Q&A session will be answered in a Q&A document, which will be sent out following the workshop at the end of all 4 sessions. So you will be able to get an overview of all the questions and answers that were asked then and the ones that we weren't able to get to. And I think that about covers everything from a housekeeping perspective. Let us know if you're having any trouble seeing or hearing our presentations, and we will work to remedy that as soon as possible. And once again, we are really glad that you're here. So at this point, I am going to turn it over to Georgia to give us her presentation on ACR updates and an overview of what we're working on as a cancer registry as a whole. So thank you again, and I will be speaking to you later in this workshop.
Thank you, Juliet. You've got to let me share the screen.
You should be good to go.
Okay. Can you see anything now?
I can see your slides, but not the presentation view.
Okay, so hold on. Can you see it now?
That looks great. Actually, I think that is the notes screen.
Is it good now?
There we go. That is perfect.
Okay. Hold on. Once I do that, hold on a sec. I got to get out of it for a sec, just because I wanted to say hello to the participants. I saw a lot of familiar names, not faces, but some familiar names and some new names. So we've got quite the registrar attendance, so that's great. So I want to welcome all of you to the ACR 2024 Annual Educational Workshop. I will start off with an overview and updates from the Arizona Cancer Registry. And so I'm going to stop my video for a sec so that I can get into my presentation. It takes a minute to... Okay, are we good now?
Looks great.
Okay, great. Thank you, Juliet. And Juliet, you'll let me know how we're doing on time, right?
Absolutely.
Okay, great.
You want a 5-minute warning?
Probably give me 10 minutes, and then depending on where I am, I may have to speed up some of the slide discussion.
Sure thing.
Okay, great. So here's a slide that covers my objectives for my presentation and what I hope to cover, but not necessarily in this order. I think it is important to share what other projects we are involved in and how we measure success at the Central Registry. So I'll start out with sharing the latest Arizona Cancer Registry updates and national updates, discuss some of the latest numbers for timeliness and completeness of Arizona data, and information about the monitoring of hospital reporting. I'll definitely have lots of slides that kind of share with you what it entails to have a federal grant and a cooperative agreement and what those requirements are. I'll talk a little bit about our advisory committee, who is our melanoma task force. I'll share information about the new 5-year cancer plan for Arizona. For some of you, this may be a repeat, but I saw a lot of names, so I think this is going to be a lot of new information for the new registrars that are abstracting cases in Arizona. So I'm going to start out with some warm fuzzies, so that you feel some happiness before I dive into the numbers of timeliness and hospital monitoring of cancer cases, and hope that these warm feelings stay with you throughout my presentation. The focus of our workshop, Juliet touched on some of these topics. I'm going to cover the overview and updates. Dana's going to talk about the cancer burden and the data usage. Cassie's going to follow her with the plan and the coalition. And on other days, we're having Dr. Byatt present on lung and esophageal cancer. And Juliet's going to talk about all the new upcoming changes that are coming. Michelle's going to talk about some exciting new quality assurance projects that we've embarked on. And Rayanne's going to, at some point, I'm not sure what day, but she's going to talk about the operations overview and Webb reporting. So this is warm and fuzzy to me. I don't know if it is to you, but I asked at least the ACR presenters to send me pictures of their family of dogs. And so this is what I received. And so over on the upper right-hand corner, let me introduce you to Dozer, Rusty, and Bella. These are Rayanne's dogs and pets, and she loves them dearly. And then underneath her, we have Izzy and Steve, and these are Michelle's family. And so in the middle, you see Ozzy, and that's Dana's dog. And he just had a birthday, and they apparently celebrated his birthday, and that's the birthday picture. Isn't he so cute? And then on the left-hand side, we have Juliet's family of Stella and Blue. Now, aren't these the cutest pet animals? Yeah. So keep that warm, fuzzy feeling as we go through some of the slides that I'm going to talk about. Okay. I thought I'd start out with our agency and kind of give you an idea of how our agency is divided or sectioned. We have the Office of the Director, we have Policy and Intergovernmental Affairs, which Juliet mentioned that we are now part of. We have licensing, we have preparedness, and preparedness is like infectious disease. They handle COVID, all those kinds of things when you think about preparedness. Prevention, those are, for example, our partners. The breast and cervical screening program are in that section. So we work with a lot of teams in preparedness and prevention. We have financial services, we have information technology, we have our HR, human resources, and the Arizona State Hospital. So now I'm going to focus, we call it PIA because Policy and Intergovernmental Affairs. So you'll hear me refer to PIA. I'm going to cover that section. But you can see that Juliet actually stole some of my thunder here in the next couple slides. I won't repeat everything, but this is the slide that she went into detail with. I can tell you that we work a lot with Administrative Rules and Counsel. Those are the team we work with in terms of our rule reporting and when we have issues. with cancer reporting. That's the team we work with. The Office of Health Equity is kind of one of those cross-cutting strategies for the agencies. And we work with the team to help put equity into action within our agency as well as our communities. And so I look at it from the perspective like we're so focused in data. And so that team helps us to data visualize with an equity lens. And so that program is very important to us. And Juliet mentioned the intergovernmental relations with our tribal, county, and border staff. And again, Juliet went through this, and so I'm not going to focus on this, but I have some more details in regards to our team in terms of what they are involved in. But I think, not a biased opinion, but I think we have the best team. So yeah. Let's see, the other thing I want to mention that Juliet mentioned is that we still have that vacant business analyst position. And so I'm hoping in this next year, cross your fingers, that we're able to fill that position. Okay, so I'm going to switch gears now and kind of talk about some national programs and how they affect the work that we do. So this is the North American Association of Central Cancer Registries, and they develop and promote uniform data standards for cancer registration. They truly are the umbrella organization that brings the standard setters together in order to decide what changes that we're going to see in the future. And they really are an advocate for facilitating data exchange. They are the ones that came up with this national agreement that we have, most of the states have signed on to. They aggregate and publish data. They certify population-based registries, and I have a slide that's going to talk about that. They also provide education and training. They have developed things that enhance the quality of our data. And a lot of that comes through the regular data submissions that we do to them. So we'll talk a little bit more about that. And they also promote the use of cancer surveillance data. So we're one of the registries that participate in this virtual pooled registry cancer linkage system. And we've been able to perform many research linkages with our data. And I know Dana's going to touch on that in her presentation. So last year, I really talked a lot about the mid-level, how changes are done nationally. And so I talked about the mid-level tactical group and the high-level strategic group who was representative in those groups and what their purpose was. And this slide was to kind of give you a better idea of how the work is done. And so this is kind of that structure of NACER. And the lower boxes are where all the work is done. And so, for example, the standardization and registry development priority area. So this is the group, and this is just some examples. They establish consensus standards and best practices for the collection and processing of cancer and patient information. Research, the next box next to it, research and data use priority area. They really are, their focus is to increase the use of central cancer registry data. Professional development priority area, really, and we see this at National Cancer Registry Association as well. It's the development and implementation of strategies to recruit and retain personnel in central cancer registries by enhancing career opportunities for individuals with diverse skill sets. And then communication, they're focused on strengthening NACER's ability to capture and share member views, opinions, and perspectives on important registry issues. And strategic planning, there are the group with tasks with moving forward the strategic plan for the organization. So I can tell you that all the work that's done is in those specific work groups and task groups, because there are a lot of committees under all these various boxes where the work gets done. I can also tell you that the executive director recently retired from her position, Betsy Kohler, and they have appointed a new executive director. Her name is Karen Knight, so you'll probably seeing her name a lot more. She previously worked for NACER, but she's also held some very high-level positions. She used to be the director of the North Carolina Central Cancer Registry. And she was also moved around in North Carolina in terms of health stats. And I know she was at the National Center for Health Statistics as well. So she brings a variety of a background, and I'm really pleased that they filled the position with Karen Knight. Okay, so I briefly mentioned certification, and so this is a table that shows when we submit data to NACER, what are they looking at? And this is an example of those things that they look at. They look at how complete our data is. They look at how complete age, sex, race, and county is. They look at our death certificate rate. They look to see that we don't have very many duplicates in our data submission. They look to see if we pass edits. And obviously, if we report data, then we're usually timely at reporting it. So the next column after that is gold and silver. You can see what they're looking for in order to be called a gold certified state versus a silver certified state. And then what I did was I provided you with the last 3 years of our data submissions. So I'm going to focus on 2021. You can see that we were at 95.9% complete. Where you see we struggle is, even though we're gold race information, we are at 3.1%. So we're kind of in that borderline where a couple of percentages more and we would have been silver. So that's something we're struggling with. And I know we always talk about collecting race information when you're looking into charts and kind of trying to find that, because I know many hospitals don't they don't record it anymore. And so you have to kind of go digging in the medical chart to find that information. And so death certificate only cases, we were at 0.9%, which is really great. And so thank you for those hospitals that have already submitted their death certificate cases back to Michelle. What's helped us tremendously is that we also now have access to the Health Information Exchange, and we're able to look up patients that are maybe expired outside of a hospital and in a hospice, for example, and to look for those records in the Health Information Exchange. So that's helped tremendously. Duplicate primary cases, you can see that we did very well at 0.0. And in terms of final outcome, we got gold. And so that is really a tribute to all of you submitting cases and making us more complete in terms of completeness, timeliness, and accuracy. Okay, so now I'm going to switch gears and I'm going to talk about the Centers for Disease Control National Program of Cancer Registries. Many of you, I think I put this slide in every year, and it's just for the new people out there that don't know that we are one of those funded states where we have a cooperative agreement with CDC. And CDC was passed with an Amendment Act, and that they are tasked with improving existing cancer registries, but they also were tasked with planning and implementing registries where none existed. They had to develop model legislation and regulations for states to enhance the viability of registry operations. And they set standards for data completeness, timeliness, and quality. They provide training for registry personnel, and they've helped to establish a computerized reporting and data processing system. So looking at the map, I just want to say that all those in blue are funded, with the exception of where those red dots are. And those states that are not funded through CDC are New Mexico, Iowa, Connecticut, and Hawaii. So you can see most of the US does have some kind of cooperative agreement with CDC. We have currently 3 funded programs through this grant, not just the cancer registry, but we also have our breast and cervical screening program here at ADHS that is funded, as well as our comprehensive cancer control program. Okay, so I want to talk about some of the national initiatives related to both CDC and to NACER. And I may not talk about all of these that I've listed, but I'll highlight a few of them. First, I'm going to start out with CDC and PCR, and they're really embarking on some data modernization initiatives. And one of them is specific to this cloud-based computing platform that I mentioned on the slide. So they've been working with the Association of Public Health Laboratories in the Informatics Messaging Services platform. And what it is, it's a secure cloud-based platform, and it provides the national labs, it allows national labs to send pathology reports to several registries at one time. And so we've working on this initiative with CDC, and I think we have at least 6 labs that are reporting through this method. And so we're really trying to push more labs to report to this through this method. And Rayanne's kind of the spear, she's leading that charge for us for sure. The STAR project, that is a Childhood Cancer Survivorship Treatment Access and Research Act that empowers CDC to improve early identification and track the epidemiology of childhood cancer. They have developed a cloud-based national oncology rapid ascertainment hub, and that helps to analyze lab reports and process data much faster. The other, now jumping to NACER in terms of what they're focusing on is they're definitely improving data quality through requirements of our data submission. And one example of that is, and Michelle will probably touch on this, but they've developed tools like, we call it Match Pro, and that is a deduplication tool that allows us to look at patient and tumor level dupes. And it's a very precise tool that identifies things that our other software that we currently use doesn't necessarily identify. So it's been a great tool to use. And I know they're also embarking on initiatives related to geocoding, to fine-tuning geocoding that states in terms of state submissions. And so those are kind of some of the initiatives they're working on. They are also working with the National Cancer Institute on the National Childhood Cancer Registry. And this is pooled childhood cancer data from many state registries across the US, and the purpose is for research. We know that when you look at a state, the numbers are not great, but when you pool when I say great, that's a good thing. But in terms of research, the really power is in the number of states that participate in order to give the researchers enough cases to do the research that they need to do. And so that's a good thing. Arizona is not currently participating, but that is something that we are looking toward in the future. Some of the overarching interest, I'm hearing over and over again that nationally, they want data quicker than 2 years. And they're looking at potentially at a 1-year marker in terms of what is it going to take to get the data within 1 year. And they're having national conversations. They've even talked about the discussion of a minimum data set. But I can tell you that that sounds great, but eventually they're going to want all the data. So initially they may want a minimum data set, but eventually they'll want the whole data set. And so there are discussions nationally going on both at CDC and NACER about how can we accomplish getting data faster. And so you'll probably hear more about that in this coming year. The other thing that I mentioned is related to the USCDI, and it has to do with health data, technology, and interoperability. There are some proposed rules related to the electronic health record that they are transitioning to what we call an HL7 FHIR, Central Cancer Registry reporting content. And what they're hoping is that this is passed nationally because if it's passed nationally, this standard, and it just doesn't involve cancer. There are other programs that this affects, but their cancer is a small piece of it. But they are suggesting specific data items related to cancer registry collection. There's 23 data items proposed. And if this passes, what we're hoping is this will help at the provider level and the information we get from the providers. And the last thing I'll mention is the Counting Veterans Cancer Act. And this was passed to improve care for vets by ensuring all data on veterans diagnosed with cancer are captured and reported to states, CDC and ACR. There is a lot of interest in Arizona, and that is because Mark Kelly, our senator, sponsored that initial bill. And so every so often, CDC asks for an update of what's happening in Arizona related to veterans, the VA hospitals reporting, and I am happy to report that we've received data from all 3 VA facilities in Arizona. Okay, now I'm going to circle back to our agency and kind of just touch on a couple things. So here at ADHS, we are celebrating 50 years of health and wellness. So yay! So proud that we've been in existence for 50 years. And but also on the flip side, I can tell you that I've been here for more than half those 50 years. That's really an eye-opener for me when I think about that. Going on, our agency has been accredited by the Public Health Accreditation Board since 2017. And you ask what that means is the accreditation process really focuses on improving our public health services and outcomes by implementing quality improvement practices. And I can tell you that the agency has done a lot of work around continuous quality improvement. Yeah. I can also tell you that we do have a director, as much as a lot has been in the news about directors of agencies, and I wanted to tell you that we do have a director. Her name is Jenny Kuniko. And we're just made aware we have a new statewide logo. And so that logo that you see on the upper right-hand corner with the green is our new statewide logo. So you'll probably see our new PowerPoint slides transition to this new logo. So that's what the new logo looks like. Also, you know, Arizona's weather has been in the news a lot lately. We've had a lot of over 100-degree weather. And so the governor issued an executive order. And so with that order, we now have a new chief heat officer, Dr. Eugene LeVar. And the new program that he manages is extreme weather and public health. And so I would definitely encourage you, and I have that last bullet point, to visit our website, because we got a lot of good information about this new heat plan, as well as other things that the agency is responsible for. So I'd encourage you to visit our website if you haven't lately. And the last bullet point, or not last, but the new data request process. So if you have a data request, we request that you don't email Dana directly, although she'd be happy to respond. We have this new process, and that's the link that I provided on your slides. And so you would put in your request through that method, and eventually it will get to Dana and Dana will respond. So that's the new process within our agency. So I'm going to talk about a little bit about our quality initiatives. And these are things that we're doing to improve data. We're following national standards. I can tell you in Arizona, we don't have Arizona-specific data items that we've defined. We just follow our national standards. And generally, what I can tell you is, in terms of the data items that we require, We follow CDC guidelines, and so because we receive funds from them, we're required to follow all the data items that they require, and that's generally what we do. To improve our data, we do a lot of data linkages. We do linkages with Indian Health Service to avoid misclassification of American Indian cases. We do linkages with the SSDI and the National Death Index to update our date of last follow-up information. We do linkages with vital records, with death certificates specifically. We do linkages with our screening programs. We also do linkages with the hospital discharge. And you'll probably remember that because when Michelle sends you the death clearance cases, she also sends you a separate list where we link our data to hospital discharge. And that's, again, in order to improve the data that we collect. Edits, we do immediate and batch editing. You know from your submissions that we do an immediate edit check. And if your file fails, we send it back to you. We also do on a quarterly basis, the SMAT Pro linkage, where it identifies patient and tumor dupes. We do audits, for example, and an example of some of the recent audits, if we've asked you to resubmit your file, it's because we're looking for missed cases. And that's actually an easy way to do a case finding audit that's less stressful for you and less stressful for us as well. We do submit data to our national partners every year. Webb Plus reporting, which Rayanne's going to talk more about, but we use Webb Plus both for our hospitals and for our physicians and clinic reporting. And I can tell you that we're going to push Webb Plus heavily in this next year to transition most hospitals to Webb to report their files through Webb Plus. We also submit our data for certification. We continually monitor cancer reporting, and we're performing evaluation on our own process throughout the year. Okay, so last year I walked through hospital-specific measures, but I think it's important to share what is happening at a central registry. CDC requires us to measure our processes, and so now I want to walk you through through all the performance measures that we are required to report on twice a year. And when I say talk about performance measures, it really is how well did we as a registry meet the CDC program standards. And so as we walk through this next few slides, you're going to notice that CDC really focuses on electronic reporting, improving the quality of the cancer cases through data linkages, and improving completeness. And they want to know how we're using our data. They don't want us to just collect it. They want to know how we're using it. And they're specifically asking us questions of how we're using it. So we're going to kind of walk through this. And so the performance measures are numbered on the left-hand column. The description is in the middle. CDC has a target of what they want us to accomplish. And so that's the CDC target. The middle column there is ACR year 2 outcomes. So that we just finished year 2 of our grant cycle. And so this is how we did in year 2. And the last column is, hey, did we meet that target? And so, for example, performance measure 1, they want us to review our state legislation every year. And so CDC's target is once a year. And so, yes, we did meet that target. Key positions filled, they want a program director, they want a training and QA manager, and they want IT staff to assist the registry. And so their target is 75%. We can see that we've hit that target at 75%. We actually want to be at 100%, but we haven't been able to fill Keith's position, and that's why we're currently at 75%. Performance measure 3, they want us to review and update our operations manual every year. And they also include in that discussion like our abstracting and coding handbook and any guidelines that we distribute. And so they want us to take a look at that twice a year, and we've met that guideline. They want us to review and update our data management plan. A data management plan contains usually a description of your data, standards for collecting data, access to our data, description and release of data, and preservation of data. And so they want us to review that every year, and we've done that. So we've met that performance measure. Performance measure 5, they want us to verify and update reporting sources. And this is really getting at, they want us to make sure that we have an active list of all of our reporting sources and we maintain it. And you know, Julia does that. So we were, and we actually distribute that to you at least this past year. We did it 3 times this year. Check in with reporting facilities. And so this is kind of a biggie, because they want us to frequently check in with reporting facilities to ensure timely reporting of cases. And you can see that their standard is 12 times a year, but you can see we met it only 10 times a year. So that's something that we can work on for sure. So the next performance measures are 7A and 7B are related to those delinquent facilities. And they want to ensure that we have remediation plans in place. And so these are your action plans. And they want us to communicate with those delinquent facilities frequently. And so you can see that we actually, they don't have a standard in this category, but you can see the number of times that I communicate with all of our delinquent facilities, that we communicate back and forth, and that you're providing those progress monthly progress reports. And so that's what it's important, and I have to track that information. Looking at 8, 9, 10, it really focuses on electronic reporting, labs, hospitals, non-hospital facilities. For labs, they haven't determined yet what that target's going to be, but you can see that we're only 57% reporting electronically. So we've got some work to do. In terms of hospitals reporting, we know all of our hospitals reporting electronically, so that's kind of an easy get for us. They want all states to be at 100% by the end of a year 5. And so usually our grant cycles are 5 years. And so that's why they say year 5. By the end of the 5 years, they want everybody to be at 100%. Non-hospital facilities. So these are our physician reporting, our clinic reporting. You can see that we have a lot of work to do in this regard. And Rayanne's going to talk about that in her presentation. So going on, so the PM 11, a number of reports created as part of program monitoring. And so these are internal reports and external reports. And so an example of this is when I was supplying hospitals those reports that Keith created that showed you how you were doing in terms of timeliness and completeness. Those are examples of reports that they want to see. And so they don't have a target, but we've been lucky to have been able to create lots of internal and external reports. And so that is something in this next year we need to work on, because we haven't been able to fill that position that is key to helping us to monitor and create reports. You can see that 12A and B is related to data exchanges. The first one is states and territories. They want us to exchange data at least once a year. We've met that target. Our neighboring states, 10 minutes? Okay. Okay, so Juliet just told me 10 minutes, and so I'm going to speed this up. I'm not going to talk about everything, but you've got copies of the slides. You can kind of see where we fall in and where we have to do work. And so the only thing I'll say is we need to increase physician reporting, and we're certainly working on that. The number of linkages, you can see where we fall in. We've been able to meet those targets. And this was just a slide to kind of share with you what 2022 looks like and what 2023 looks like in terms of non-resident cases and what's being reported. You can see that most of the cases are California resident cases, followed by New Mexico, followed by Nevada. Yeah, and so this is very important because we do have data exchange agreements in place. So we're able to send these cases back to their resident home state. Okay, so going on, number of linkages with Indian Health Service, we do that every year to avoid misclassification of American Indian cases. The number of audits, you've seen that we at least conducted 8, and these are mostly related to resubmission of cases, but they want us to touch each hospital by the end of the 5 years. And so if you haven't been audited, you will be audited in the future. And so 24 PM performance measure 24 has to do with report writing and presentations and how we're doing. And you see that we've been able to hit those targets. This one, performance measure 28, talks about the number of advisory committee meetings. You can see that we actually meet every other month. And so we've been able to meet that target. And the number of data quality improvement initiatives developed, we've been able to hit, and quality assurance measures implemented. So I'm going to quickly go on the next few slides. So this, you will notice some themes as we go through the next few slides. This is the work plan that we have submitted to CDC, and you can see that we are really focused on electronic reporting. 3 of the objectives are focused on electronic reporting, and 1 is related to monitoring of Arizona hospitals. And so we're really looking to expand provider and clinic reporting through electronic methods. And so that's where a majority of our focus is on, as well as path labs. And then the last one, 4.1, is really focusing on increasing timeliness of Arizona hospital reporting. And so that's on our work plan that we're going to be focusing on in this next year. Evaluation, I'll just say a few things about this. We perform evaluation to improve the collection of cancer data, to increase and improve access to data through collaborative efforts to support cancer control activities, and to accurately describe the burden of cancer among Arizona residents. And so our focus on evaluation is looking at timeliness, quality, and completeness of data. We also are focusing on data submission to CDC and electronic capture of cancer cases, including participating in any CDC data modernization activities. And we're collaborating with our B&C program and our advisory committee. And I just listed some examples of what we'd be doing and targeting for that area. And some of the focus questions that we ask ourselves, for example, does the ACR meet the CDC and PCR standards for timeliness? Do we measure timeliness of cases? And so those are kind of activities that circle through evaluation. Okay, so I'm going to take a breath here and kind of put it all together for you. What are we doing and what do we have planned? We're obviously going to continuously perform data monitoring and management reporting. And the first thing I'm going to start out with internal management meetings about reporting challenges. So we've had internal management meetings where upper level was involved. And this is an example of some of the information we shared. And so I'm going to toggle between slides. And so this is looking at timeliness. So every row here is a hospital. So think of it, every row is a hospital. And what we were measuring, we were looking at cases submitted in 2023. So that's the first block of columns. And then the second block of columns is those cases that were submitted in 2022. And then the last column was actually what year was that hospital reporting on. And so if I look at that first row, or after the on time row, I look at that hospital And you can see that for 2023, a majority of their cases were 51% were submitted in the 7 to 12 month range. So that's not good because we want everybody to be on time, at least the majority of their cases on time. So, and that hospital was reporting on 2022 data. So this is an example of management reports that I'm sharing with upper management. All of these hospitals at the time when I produced this should have been reporting on their 2023 data. So you can see that we've got some hospitals that are right on target and others that are fairly delinquent. And so this is an example of the monitoring that we have to do. And we do share with management. Okay, so the other thing that the agency embarked on is over a year ago, the agency also developed a metric or a performance measure so the cancer registry is part of a larger group where we had to report the number of cases that were reported on time. Okay, so I'm going to tell you, this is what it looked like. And this is when I started submitting this to upper management. That was July of 2023, all the way through June of 2024. So again, this is percentage of cases reported on time per regulation. So you can see we're not doing so well. And again, when I say on time, this is an example of what I mean by on time. And I'm going to end up redoing this and posting it to the website, but I want you to focus on the yellow part. So we are about to be in October of 2024, and you will start sending those October submissions. All hospitals should be reporting on data through March of 2024. And I can tell you that most hospitals are not there. So this is something I'm going to recreate with more timely information. It will be posted to our website and you will be notified. So when we talk about on time, this is what we're talking about. Okay, the last couple of things that I'm going to probably rush through is talk about the new cancer reporting objectives that we've created for the 5-year cancer plan. I have it listed here, but I'm not going to talk about the dashboard, but we are on our radar is to develop an internal dashboard that will help us with cancer reporting monitoring. And I'm going to briefly touch on rules and how we're about to embark on rule making. Okay, this is where we stand right now in terms of what do we look like for 2022, 2023 completeness, because we're so focused because we got an upcoming data submission. So I'm going to focus on percentage. I've got in the third column over 2022 data where we're at right now in terms of completeness. We are at 80.4% complete. For 2023, we are 56.76 complete. So this is the issue. What are we missing? Well, I can tell you, we're missing a lot of hospital cases. But we also know we've got cases sitting in our subsystem that we've worked on related to lab, related to out-of-state data exchanges, related to physician clinics that we haven't moved up to the main system. So they're not counted yet. But I can tell you, based on all the information, we are missing lots of hospital cases. And so that's where we're at. So we're going to really be pushing those hospitals that still have outstanding 2022 data to really get those last few cases into our system. And I'll just say this, you've seen this before, those hospitals that are delinquent are still required to submit monthly progress reports. These are the things that I want you to talk about in the monthly progress report. We know the format of these monthly progress reports are going to change in this next year. And so you'll be hearing about that. And we know the reports that we traditionally send to you will be changing as well. And so that format, and we'll notify you as soon as that is done. Compliance issues, these are the teams that we work with when we have compliance issues. Our first stop is Administrative Counsel and Rules. And then if we have to involve licensing, we haven't yet, but we are starting with Administrative Counsel and Rules. And these are the groups we work with. Okay, so one of the things I mentioned is that we have a new objective that's in the cancer plan. And this objective is the percentage of cancer cases reported on time according to regulation will increase from 27% to 75%. Our strategies are we're going to develop and disseminate materials on the importance of cancer reporting signed by coalition stakeholders with the goal of informing hospital administrators. We are going to develop and implement a quality improvement process that incorporates sharing of hospital cancer reporting information with the goal of encouraging more timely reporting. And we're going to increase electronic cancer reporting from providers and clinics. I can tell you within the coalition that this objective was signed to the policy work group. We have on October 10th, American Cancer Society Cancer Action Network Cancer Summit, and this objective will be discussed with the stakeholders, and we're going to strategize on how we go about accomplishing this. And so this is going to be at the forefront of what we do in working with our stakeholders to improve specifically hospital reporting. The other thing I mentioned is that we are currently reviewing our 5-year rule review, and this is an opportunity to review our articles and discuss things that are good and what needs to change. We're reflecting back on the last 5 years, providing information about the average number of reports received per year from hospitals, clinics, physicians, and path labs. And we're responding to a series of questions in terms of the regulations. Are the rules clear, concise, and understandable? So we've completed that process, and we've been given the go-ahead to start rulemaking. And so we are looking at our regulations and to see how we can improve them and to make sure they are clear, concise, and understandable. I have a few slides left, so I'm going to kind of rush through them. So the Melanoma Task Force is our advisory committee. The representatives are on the left side of who's on this committee. The purpose is to enhance melanoma reporting to the Arizona Cancer Registry and promote the use of registry data and control of skin cancer. Again, I've outlined what some of those deliverables are. We meet every other month. They are definitely helping us to with data quality improvement initiatives, but they also are involved in the Arizona Cancer Plan. And I think that's the next slide. So this is just an example. If you have not seen our melanoma newsletter, this is what it looks like. This is the kind of information that we provide in that newsletter. It's on our website. The thing that I wanted to point out is in that middle graph, figure 3, because we're always being asked, does Arizona have the highest rates? You can see that Arizona has higher rates compared to the US. We don't know if that's just a statement that Arizona does have higher rates, or are we better at reporting data? And then that is only because this task force has really assisted us in getting physicians and dermatologists specifically to report their melanoma cases. And so, yeah, that's where we currently stand compared to the US. And I'm happy to say that the reports come from not just doctors of medicine, but we get a large chunk of them from physician assistants. And so you can see at the lower graph that 24% of our cases come from physician assistants. And so definitely, if you haven't checked out this newsletter, go to our website and check it out. And the last thing I want to say about the task force is this is the objective that they're involved in the cancer plan. They're going to help us to decrease the percentage of late-stage melanomas diagnosed in Arizona by 5%. These are the strategies that we're embarking on. So we're excited about that. We actually have a meeting tomorrow, so we're going to start actually diving into this objective. So we're excited about that. And in summary, I just want to end with these priority initiatives. We're going to continue to monitor reporting from all sources. We're hoping to develop a more robust monitoring program, which includes development of management and hospital reports. We're reviewing the quality of specific data items. We're going to continue to look at completeness and timeliness and have probably a more targeted monthly progress reporting process. Again, quality initiatives that are going to focus on timely, complete, and quality data. We are about to embark in rulemaking for our regulations. We're hoping to increase electronic reporting from our non-hospital sources, specifically about hospital reporting. I think we're hoping to transition most hospitals to Webb Plus reporting. And we're probably going to institute the initiation of the startup again of follow-up files. And so stay tuned for that for sure. So I want to leave you with another warm and fuzzy because Dana is coming up next. And so these two dogs, Kova and Harvey, they're getting ready for Halloween. And so these are my young adult kids, Huskies, and I love them to death. And so don't they leave you with a warm and fuzzy? So I'm hoping for that for sure. So I want to thank you for your time and attention. Thank you.
Thank you so much, Georgia. And Dana Doyle, our epidemiologist, has the next presentation. So give us just a moment while we change seats over here.
Hello, everyone. Hi, now I'm unmuted. It's so nice to meet you all. I am a pretty new face. I was at the last annual meeting. So for those of you who haven't met me, I'm Dana Doyle. I'm the Arizona Cancer Registry epidemiologist. And today I'll be going over Arizona's cancer burden and how we use Arizona Cancer Registry data. So just give me a second to pull up my slides.
Great. And I think we need to share the screen. I'm just gonna share screen. Screen table. Got it.
Awesome. All right. Thanks everyone for bearing with me. Today, what we're going to be talking about is our objectives. We're going to provide an overview of the most recent 5 years of Arizona Cancer Registry incidence and mortality trends. So we'll be talking about incidence data for 2017 to 2021 and mortality data for 2018 to 2022. We are going to be highlighting specific cancer sites, our top 5 for Arizona, and going through age-adjusted rates for race, ethnicity, sex, county, and stage of diagnosis. And we'll be discussing how Arizona Cancer Registry data is being used in public health and some examples of that. And just some reminders as we go through looking at trends for Arizona Cancer Registry data, it's important to remember the impact of COVID-19. We did see an impact on our counts and age-adjusted rates for 2020 and 2021. We did see that for 2021, those counts are starting to rise, but they still are lower than we would expect. And these fluctuations in data could be due to delays in diagnosis, lack of screening, and disruptions patient treatment follow-up care, and also just contracting unforeseen health complications due to COVID-19. And when we talk about incidence, we're referring to the new number of cancer cases being diagnosed, mortality referring to cancer deaths. And I'm going to be saying the word rate a lot, and just know that I'll be referring to age-adjusted rates. which is the number of people who are diagnosed or died from cancer for every 100,000 people. And like I said, this presentation will include the most updated data that we have available. So for instance, 2017 to 2021 and mortality data for 2018 to 2022. And of course, as I say this, I am, hold on one second. Apparently my slides are not showing. There we go. Sorry about that, everyone. So there's our reminders. And then we will just go into, there we go. So like I said, I mentioned that we are going to be showing data for 2018 to 2022, but I'm showing you a mortality slide for 2017 to 2021. And this is because this comes from our vital statistics department at ADHS, and they have only 2021 data available at this time. But I just wanted to show that cancer is the second leading cause of death in Arizona. And up until 2016, it was the leading cause of death, but then diseases of the heart surpassed cancer, 2017 being the leading cause. And you can see in 2020 that COVID-19 became the third leading cause of death in Arizona, and it stayed that way for 2021. Now I'll be jumping into Arizona specific mortality data. So for now on, mortality data will be 2018 to 2022. I just want to highlight that between 2018 and 2022, we saw an average of 134 cancer deaths occurring for every 100,000 Arizonans. And the rate of cancer deaths did decrease 3.6% from 2018 to 2022. But overall, males do have a higher rate of cancer death compared to females. And the cancer sites responsible for the most amount of deaths in Arizona for this time frame are lung and bronchus, colorectal, pancreatic, female breast, and prostate cancer. And you can see in the lower right corner that for the average annual number of cancer deaths, that males do have higher than females. They account for 53% of our annual cancer deaths. And looking at mortality for Arizona by race, ethnicity, and county, we see that Black and African Americans in Arizona are dying of cancer at higher rates compared to all other race ethnicity groups. And please keep this in mind when we move to incidence. So in looking at our counties, we see that La Paz and Mojave County do have the highest rates of cancer deaths in Arizona. And we see this trend of a sash across our state going from Mojave to Cochise County. In that diagonal sash, we see our highest rates of cancer deaths. Right, and switching gears and talking about incidence. So this is data for 2017 to 2021. And we saw approximately 396 invasive cancer diagnoses per 100,000 Arizonans. And the rate did decrease 6.4% from 2017 to 2021. But I did want to highlight the impact of COVID-19. And you can see that in our age-adjusted rates from 2019 to 2020. And we saw a decrease of almost 9% within those 2 years. You can see for that 2021, it is starting to increase, but it has not bounced back to pre-pandemic numbers. And same with mortality, that males do have higher rates of invasive cancer diagnoses compared to females. Okay, and looking at race, ethnicity, and county, I asked that when we looked at mortality that you kept in mind that Black and African Americans in Arizona are dying at higher rates of cancer compared to all other race ethnicities. But when we look at diagnoses, we see that white non-Hispanic individuals are being diagnosed with cancer at higher rates. So it shows that there is a disparity between diagnoses and deaths among race ethnicity groups. And looking at county, for mortality, we saw that La Paz and Mojave County had their highest rates of cancer deaths. And we see that as well with cancer incidence, as well as Yavapai County having a high cancer incidence rate as well. Right, I'm looking at stage of diagnosis. So on this slide, I included our top 5 cancer sites for Arizona, which are female breast, lung and bronchus, prostate, colorectal, and melanoma. And I also wanted to include cervical cancer so you can see how that is being diagnosed, because that is one of our more preventable cancers, even though all cancers cannot be prevented 100%, but we do know that the HPV vaccine can prevent 90% of cervical cancer cases. And just to go over early stage, when we look at that, that's that blue column. That includes in situ and local cases. The red column is late stage for regional and distant, and unknown is that we did not have any staging information documented. And for cervical cancer only, early stage is local cases only and does not include in situ cases. So we can see, looking at these top cancer sites, that female breast and prostate and melanoma have majority of our cases being diagnosed in early stage. This can be attributed to early detection is working and our screening is working, especially for female breast cancer. But we see that for lung and bronchus and colorectal cancer, that majority of cases are being diagnosed in late stages at the time of diagnosis. And for lung and bronchus, it is hard to get screened for those cancers because you do have to meet certain criteria of being a heavy smoker for a longer period of time. But for colorectal cancer, it is interesting to have majority of cases being diagnosed late stage, even though there is an increased national effort to improve screening through at-home testing for colorectal cancer. And for cervical cancer, we do have a higher percentage of unknown cases, but for the most part, an equal number of cases are being diagnosed in early and late stages. And we would like to see those early stages increase and hopefully just lower the overall incidence rate of cervical cancer. And so now we're going to switch gears and go into our specific cancer sites. So I have 5 cancer sites that I'm going to go over today. And so this will get a little repetitive, so please bear with me. So the first one is female breast cancer. So this is our most common cancer diagnosis in Arizona. An average of 5,268 female Arizonans were diagnosed with invasive breast cancer each year at a rate of 118.9 cases per 100,000 female Arizonans. And a quarter of all female breast cancer cases were diagnosed in late stage, but the flip side of that is 71% were diagnosed in early stage, like we saw on the previous slide. And the screening recommendations for female breast cancer are that women between the ages who are at average risk of female breast cancer are between the ages of 40 and 74 receive a mammogram every other year. And when we look at it by county, we do see that Yavapai, Maricopa, and Pima counties have the highest female breast cancer incidence rates. And we look at incidence rates by diagnosis here, we do see a lot of fluctuation for breast cancer. We see that between 2017 and 2019, we saw an increase of about 5%. And then we saw that impact of COVID-19 between 2019 and 2020, where we saw a decrease of 10%. And we're increasing again with 2021 of about 5%. So lots of fluctuations that could be due to COVID-19, and maybe in the next couple of years, we'll see those numbers bounce back to pre-pandemic, but it's hard to know if people are actually being diagnosed with less cases of breast cancer or if that's those delays in COVID-19. And then looking at race ethnicity, we do see that white non-Hispanic women are being diagnosed with female breast cancer at higher rates compared to all other race ethnicity groups. And for mortality, female breast cancer is the 4th leading cause of cancer death in Arizona, with an average of 902 female Arizonans dying of breast cancer each year at a rate of 18.8 deaths per 100,000 female Arizonans. And La Paz County stands out as the county with the highest female breast cancer mortality rate in Arizona. And looking by diagnosis here, we see less fluctuations in this female breast cancer mortality rate. Between 2018 and 2022, we saw an increase of about 6% in that rate. And for female breast cancer, for instance, we saw that white non-Hispanic women are being diagnosed at higher rates, but Black and African-American women are dying at higher rates of breast cancer. And we do know that Black and African-American women are more likely to be diagnosed with triple-negative breast cancer, which is a less common, more aggressive, and harder to treat form of breast cancer. And our second cancer site is lung and bronchus cancer. So this is the second most common cancer diagnosis in Arizona. An average of 4,049 Arizonans were diagnosed with invasive lung cancer each year at a rate of 42.7 cases per 100,000. And this is one of those sites where we do see majority of our cases being diagnosed in later stages, with Mojave and La Paz County having higher lung cancer diagnosis rates compared to all other counties. And we do see not really a lot of fluctuations in the lung and bronchus cancer incidence rates, we do see a decrease of 7.8%. Between 2017 and 2021. And then for race ethnicity, we do see that white non-Hispanic individuals are being diagnosed at higher rates, followed by Black and African Americans in Arizona. And for mortality, lung and bronchus cancer is the leading cause of cancer death in Arizona, with an average of 2,563 Arizonans dying from lung and bronchus cancer each year, a rate of 26.3 deaths per 100,000 Arizonans. And looking at our map, once again, Mojave and La Paz County do have the higher mortality rate for lung and bronchus cancer, as they did with incidence. And then we do see that for, by diagnosis here for lung and bronchus cancer mortality, I should say year of death, we do see a significant drop in cases, about 17% between 2018 and 2022. And white non-Hispanics and Black and African American individuals do have an equal rate for lung cancer mortality, even though white non-Hispanic individuals were being diagnosed at higher rates. All right, our third cancer site is going to be prostate cancer. So an average of 3,702 male Arizonans were diagnosed with prostate cancer between 2017 and 2021 at a rate of 81.2 cases per 100,000 male Arizonans. And this is one where we do see 23% of our cases being diagnosed late stage, but 66% are being diagnosed in early stage, which is great. And we do see, looking at a county map, that Navajo County has the highest prostate cancer incidence rates in Arizona, followed by Yuma, Pima, and Maricopa County. And looking by diagnosis here, we do see that between 2017 and 2021, a drop of almost 19%, but that there is a large drop between 2019 and 2020 of about 17% in the rate of prostate cancers being diagnosed. And looking by race ethnicity, Black and African American males are being diagnosed with prostate cancer at much higher rates compared to all other race ethnicity groups. 121 cases of prostate cancer per 100,000 male Arizonans. For mortality, prostate cancer is our fifth leading cause of cancer death in Arizona, with an average of 752 male Arizonans dying from prostate cancer each year at a rate of 17.6 deaths per 100,000 Arizonans. And Navajo County, once again, has the higher mortality rate, along with the highest incidence rate for prostate cancer. And looking at this by year of death, we do see less fluctuations with mortality rates. With from 2018 to 2022, we see a decrease of about 5%. And once again, Black and African Americans do have a higher prostate cancer mortality rate, as well as that higher incidence rate for prostate cancer. Right, we have two more cancer sites to go through. Our fourth most common cancer site is going to be colorectal cancer. So an average of 2,796 Arizonans were diagnosed with invasive colorectal cancer at a rate of 32.1 cases per 100,000 Arizonans. And this is one that we mentioned where a majority of cases, a little over 50%, are being diagnosed in later stages despite national screening efforts. And Graham County sticks out as the county with the highest colorectal cancer incidence rate in Arizona. And we do see that there was a decrease of almost 10% between 2017 and 2021 for colorectal cancer incidence rates. I said it's hard to know if that is due to COVID-19 or if people are actually being diagnosed with less colorectal cancer. And then looking at by race ethnicity, white non-Hispanic individuals are being diagnosed with colorectal cancer. 34 cases per 100,000 people, and there is less fluctuation between these race ethnicity groups. They're closely followed by Black and African Americans in Arizona. And mortality, colorectal cancer is the second leading cause of cancer death in Arizona. An average of 1,129 Arizonans died from colorectal cancer each year at a rate of 12.3 deaths per 100,000 Arizonans. And Mojave County stands out as the county that has the highest mortality rate. And looking at the by year of death, we did see a decrease of almost 5% between 2018 and 2022, and that Black and African Americans are dying at higher rates of colorectal cancer compared to all other race ethnicity groups. All right, and this is our last cancer site, the last data heavy slides. So thank you for hanging in there. Melanoma is the 5th most common cancer diagnosis in Arizona, and an average of 2,791 Arizonans were diagnosed with invasive melanoma each year at a rate of 31.7 cases per 100,000 Arizonans. And we do see 5% of those cases being diagnosed late stage and 93% being diagnosed in early stage, which is really great. And we do see our county map looks a little different here. A lot of counties in that higher range, but Yavapai, Pima, and Maricopa counties have the highest melanoma incidence rates. And then looking at by diagnosis here, we do see an actual increase in melanoma cases being reported, almost 7%. And like Georgia mentioned, this could be due to the fact that Arizona is really good at collecting these cases, because we do have a higher melanoma rate than the rest of the county. I'm sorry, the rest of the country. But yes, we are seeing our case counts and rates increase. And for instance, we do see that white non-Hispanic individuals are being diagnosed a lot more than other race ethnicity groups for melanoma. Right? And lastly, melanoma, it's our 17th leading cause of cancer death in Arizona. An average of 212 Arizonans dying from melanoma each year at a rate of 2.3 deaths per 100,000 Arizonans. And Yavapai and Mojave County are those counties with the highest rates, with about 3 deaths per 100,000 people. And we did see a decrease in melanoma deaths, about 12% between 2018 and 2022. And once again, white non-Hispanic individuals making up have the highest rate of melanoma mortality from 2018 to 2022. Okay, so that is it for our data. And so now I just kind of want to briefly talk about how this data is being used. So all the work that you do to getting these cases to us and is not just sitting in our database collecting dust, it is being used regularly. It is extremely important to understanding Arizona's cancer burden and informing evidence-based practices that can improve diagnosis and treatment outcomes for patients and survivors. Like George said, we do consider our data complete for 1995 to 2021 diagnosis years. And to improve the quality of our data, we do multiple linkages with our partners, such as the CDC-funded Breast and Cervical Cancer Early Detection Program, Indian Health Services, and VA facilities, as well as our death clearance process. I don't want to talk about how our data is being shared with a lot of research and data requests. One that I really wanted to talk about is how we work with the virtual pooled registry that is under NACER. So this kind of serves as a one-stop shop for researchers to submit a standardized application to multiple state registries to collect cancer data, instead of having to fill out a unique application for each state and registry. So as of 2024, we have completed 10 studies using our cancer registry data for these HSRB approved studies in our virtual pooled registry. We also have data available on our data dashboard in aggregate form and on our annual publications. And I did want to highlight that this year we launched the Navajo Epicenter Cancer Data Dashboard, which contains tribal cancer data for Navajo Nation. And this is one of the first dashboards of its kind, which is extremely exciting. So there is a link in my presentation when you get these slides, and you can check that out. And we also respond to cancer concerns in our community in providing education. And we collaborate with our programs at ADHS and our county partners to provide data for programs and interventions throughout Arizona. And so this slide is just showing some examples of that. You can look at our annual report, our site-specific infographics, or dashboard, and that is what the Cancer Among the Navajo report looks like. And above that, the Navajo Epidemiology Center for Cancer Data Dashboard. And in that lower left corner, that's the Arizona Cancer Control Plan that we are going to be talking about next. So no spoilers for that. And I will just share that we have these resources and get ready to introduce our next speaker. So thank you so much, everyone, for your time and attention. And thank you. And Cassie, would you like us to share your slides, or would you like to?
Oh, sorry, I was waiting. I have my slides pulled up. I could quick pull those up. Give me 1 second.
Perfect. And while Cassie does that, I will introduce her. So Cassandra Webb is a dedicated public health professional with over 6 years of experience in managing and coordinating public health programs and has overseen the Comprehensive Cancer Control Program at the Arizona Department of Health Services for the last 3 years. With a Master's of Public Health, Cassandra brings expertise in designing, implementing, and evaluating cancer control programs with a focus on evidence-based strategies and community engagement. Cassandra has a proven ability to lead cross-functional teams, secure funding, and foster partnerships to enhance cancer prevention, early detection, and treatment efforts. Her work is driven by a passion for improving community health outcomes through evidence-based practices and collaborative approaches. So here's Cassie Bubb.
Thanks so much, Dana. Feels very official after that introduction. I just want to make sure, can everyone see my screen? Okay, the presentation, not the presenter side. Okay, cool. Thank you. Just wanted to make sure. So again, thank you, Dana, for that introduction. My name is Cassie, and again, I work at the state for the Comprehensive Cancer Control Program as part of the same grant as the Arizona Cancer Registry. So I'm going to go through some information about our latest state cancer plan. So it is a requirement from the Centers for Disease Control that each state has a cancer plan, and it looks a little bit different depending on where you are. Some states do it for 1 year, 2 years, 10 years. Here in Arizona, our plans are 5 years long. And it's just a way to identify priorities in the state and help kind of drive the work at the state and with our partners. So the new plan just went into effect in July, so it's very, very fresh, and we're really excited to be able to share it with you all. So just again, I kind of touched on some of this already, but it just serves as a roadmap for the state and our partners when we're thinking about the work that we're currently doing and the work that we want to do to reduce the burden of cancer across the state. It's meant to be a living document, and it's created collaboratively with partners from across the state. It focuses on the top cancer sites, which is data that we get from our partners at the registry. And then it's broken up into 5 different areas of focus that span the entire cancer continuum. The work that of creating the plan and also kind of leading the objectives and implementing the strategies that are outlined in the plan is really done by the Arizona Cancer Coalition, which again is a group of stakeholders from across the state that come together kind of within these different topic areas to, during the planning process, identify these different priorities and craft the goals that we want to accomplish over the next 5 years. And then also, the boots on the ground to implement the different strategies the way that we want to accomplish those goals. So really briefly, again, thinking about the cancer continuum and kind of how we cover that, the work groups are early detection and prevention, treatment, survivorship and quality of life, policy, and childhood cancer. So I won't read all of this, but if anyone's interested, you can take a look later on. But the overall goal of the Cancer Coalition, the mission, is to reduce the burden of cancer through collaborative efforts in prevention, early detection, treatment, policy, and survivorship. So again, kind of some important things to keep in mind when we're looking at the plan. But really briefly, want to touch on the process, kind of how the plan was developed. So this was the first time that we've ever created the plan completely virtually. So we held listening sessions with the community, we held work group meetings, we talked with partners one-on-one, again, all in the goal of establishing those top priorities across the state. And while we were having those conversations, we really tried to keep guiding principles in mind throughout the process to make sure that we were, staying on track and staying true to the process and everything that we wanted to accomplish. So including diverse stakeholders, making sure we were acknowledging health equity and building that into the plan whenever possible, making sure that the process was transparent. We were aligning with other initiatives happening locally or even nationally, that we had really good data to back up the goals that we were setting, and then making sure that everything was measurable so we could keep track of our progress and see how much we were able to move the needle. Again, I kind of touched on this already, but again, it was really important to make sure that we were including as many perspectives as possible. And one great thing about doing it virtually this time around versus in-person meetings is we were able to have a much bigger reach. And at the end of the planning process, which took about 9 months, we had individuals representing over 50 organizations that have participated in the plan. So again, I won't go through and read all of these, but again, just to give like a high level overview of the different topic areas or the different continuum areas, I guess, and what the plan focuses on. So the first work group or section of the plan is early detection and prevention. And they focused on decreasing late-stage prostate cancer diagnosis, increasing lung cancer screening rates, increasing colorectal cancer screening rates, decreasing late-stage melanoma diagnoses, increasing adolescent male and females that are up to date on their HPV vaccination series, and then increasing breast cancer screening rates. So as you can probably imagine, a lot of the data, a lot of the baseline and target data, eventual target data will be, is information that we gathered from our partners at the registry. Our treatment work group focused on increasing the number of patients that are familiar with clinical trial opportunities, creating resources around kidney cancer, incidence and mortality, and then also decreasing the length of time from diagnosis to treatment for lung cancer patients. Our survivorship and quality of life work group focused on partnering with organizations to disseminate new standards of care for survivorship. Increasing patient navigation, specifically in underserved and rural communities, because we know that that's such an important tool. Decreasing the percent of survivors that are reporting food insecurity, and then increasing participation in the Cancer Experience Registry, which is a survey for cancer survivors and caregivers to share about their experience, and with the goal again of collecting really good data on what survivors and caretakers in Arizona are experiencing, so we can better serve them. Our policy work group focused on getting legislative support to expand access to patient navigation, increase state-funded cancer screenings for cancers with medical consensus, and then reestablishing Arizona as a leader in tobacco control policy. And then one specifically for the registry is to increase the number of cancer cases reported on time according to regulation from 27 to 75%. And then finally, our childhood cancer work group decided to focus on hosting opportunities for healthcare providers to learn more about childhood cancer, because it's often very unique, especially on the front end with finding a diagnosis. Develop resources that we can distribute in the community with data about cancer and kind of just general information to maybe some of those non-traditional partners, not just doctors and nurses, but folks that are in the community interacting with children who are at risk of cancer, and then support and promote community building amongst childhood cancer survivors and caregivers. So some things I just want to highlight that are new to this cancer plan. Again, first and foremost, it is 100% virtual. So we will eventually have a PDF for anyone who wants to print off a copy and keep it on their desk like I do. But for the most part, it is 100% virtual and lives on the ADHS website as part of the Cancer Coalition. This is the first time that we've done the plan this way. And a lot of benefits, obviously, making sure that we're making changes as necessary, since again, it is meant to be a living document. We're able to update data as it becomes available, update kind of the progress that we're making on our objectives. We also made sure, again, with a ton of help from Dana and Georgia at the registry, to include health disparities data throughout the plan. And I have an example of what that looks like a little later. We also include cost data. So we know that this kind of came about when we were talking about how we wanted to discuss the cancer burden with policymakers. And then we found it was a really good way to kind of share or display what the burden looks like across everyone, not just for policymakers. So that's throughout the plan. We also included social vulnerability index data. And then for the first time, we also have a letter of support from Governor Hobbs at the beginning of the plan. So we were able to, through our policy work group chair, partner with the governor's office to, obviously share about the plan and then get her support, which has been really cool. So again, just kind of some examples of how those different features or how that data is embedded in the plan. So this is specific to kidney cancer, but again, the format is pretty similar. We have hospital discharge data that we got from our EPI team about the cost of kidney cancer in hospital discharge, and then overall. And then below, we have some data from the registry on kidney cancer, and we know that it specifically disproportionately impacts the Native American population. So we wanted to make sure that we were highlighting that when we were talking about the kidney cancer objective in the cancer plan, which is under the treatment work group. We also included social vulnerability index data this time around. We thought that it was a really good way, and with kind of all the different features that we shared, we felt it was a really good way to, provided a different perspective when talking about cancer and also crafting our strategies and our objectives. So looking at this data, again, just kind of helped provide a different perspective to the burden that cancer has across the state, and also different ways that we can try and address that burden. Specifically when we're looking at tailoring, community outreach or providing resources to different communities. Next, and I realized I didn't mention it when I went over the features, but something that I love and is my favorite part is we also included stories from real Arizonans. So looking at some plans from other states and just kind of, hearing from community members, talking with our leadership team at the state, we felt that stories were really powerful. And what I kind of originally envisioned, was just kind of pulling quotes or kind of having snippets from what we had folks share with us. But our communications team, we felt like there was so much great information shared. We had our communications team actually develop a template to be able to share all of the survivor and caregiver stories that were submitted to us, which was, again, turned out really beautiful. And then finally, I know I went through a ton of information, but I always like to just save some time to actually take a look at the plan and kind of scroll through it so you can see what it looks like in real time. But for anyone who's interested in participating in the coalition or getting more information about the plan or anything else cancer related at the state, you can reach out to me. That's my email there, and hopefully it will be, I think these slides are being shared out so you can find it there as well. So with that, I'm going to quickly stop sharing and pull up the plan here. And while I'm doing that, I'm sorry, I'm not really looking at the chat here. Are there any questions? Any questions about the cancer plan?
Not at this point, but I will let you know if any come in the next few minutes. So if anyone has questions, feel free to share them in the Q&A chat.
Okay, thank you. Yeah, I know I'm sharing a ton of information and I talk pretty fast, but there's always a lot to get through. So I'm just going to share my screen again here. Okay, so I'm just going to kind of scroll through the plan here, try not to make anyone too seasick by jumping around or scrolling too fast. But this is the virtual cancer plan. Again, it lives on the adhs.gov website under the Cancer Coalition. And then again, shout out to our communications team. They did a beautiful job with the design and bringing all of these features that we talked about to life. Again, we start with our letters of support. So first we have our letter of support from Governor Hobbs, and then another letter of support from our bureau chief, who oversees all of the chronic disease programs at the state. And then an introduction. So a lot of this information I already shared with you all about kind of the context of the plan, why it's important, some information on the cancer care continuum, the development process, again, which I kind of shared about as well, but this all speaks to us wanting everything in the plan to be very transparent. And then the dedication here, before we jump into the meat and potatoes of the plan, featuring all of our survivors and caregivers that submitted stories throughout the plan. So starting off, and this is, again, a similar format from previous plans as far as the order of things, but we start with cancer data. Obviously, it's super important to set the stage for why what we're covering in the plan is talked about and why it's important. A ton of this, the majority of this data, I would say 98% of it came directly from the Cancer Registry. So again, huge shout out to that team for putting this all together for us. And again, data on incidence, mortality, health disparities data, groups that are disproportionately affected by cancer. Some data by county. Again, sorry, I'm trying not to scroll too fast, but hopefully everyone can take a look at this a little bit more in depth later on. And then we touch on the Cancer Coalition. So again, the group that really led the charge in planning, and then we'll be implementing and eventually evaluating the objectives that we established. And then the early detection and prevention work group. Again, you'll see this kind of format repeated throughout the plan, but just a really brief introduction to the work group and kind of the topic areas that they cover. All of the objectives are 5-year goals. So we kind of kick it off by saying by June of 2029, setting the stage. And then the objectives are outlined first, and then the strategies or the different ways that we want to achieve that 5-year goal are below. And then another example of that cost data, health disparities data, highlighting here that African American men are disproportionately affected by prostate cancer. And then our first story from Fred here, who is an 85-year-old cancer survivor and shared about his journey with us. And again, just kind of repeats with the different objectives, strategies, and cost and health disparities data, more survivor stories. And then I'll jump down to the policy work group because that's where we have an objective dedicated specifically to cancer reporting. Another really great survivor story. And then here we have the objective dedicated to cancer reporting and the different strategies here. And then Georgia and her team at the registry really led the charge with crafting this objective and worked with our other policy work group members to have it included in the plan. And then childhood cancer. And then at the bottom, we have some resources. So outlining the different cancer programs at the state. We have a glossary, so some terms that come up really often when we're discussing cancer or cancer treatment or, really a lot of things across the continuum that the work groups felt were important to include or have easily accessible for folks. The evaluation process, how we kind of look at the plan and measure our success, and then obviously acknowledgements for folks that contributed, highlighting the organizations that participated in the process, and then all of our really great grant information, acknowledging, that this was opportunity was provided to us by the CDC. So again, I know I talk super fast and I have been calling it my Cancer Plan Roadshow. So ever since the plan went live in July, I have been sharing about the plan. So I know that I can talk fast and I cover a lot of information in a short time. But again, just want to kind of open it up if there's any questions about the plan or about the Cancer Coalition.
No questions that I can see right now, but excellent information, Cassie, and thank you so much for sharing all that with us.
Yes, thank you so much for having me. And again, I'm going to drop the link to the plan. Oh, I don't think I can actually, but I will make sure that everyone gets a link to the plan. And also my contact info if anyone's interested in joining the coalition. That's my kind of last thing I always like to share is that the coalition is open to anyone who's interested or passionate about reducing the burden of cancer across the state. And we always love to invite new members and welcome new perspectives. So if anyone's interested in participating in the coalition, please reach out to me as well.
Well, we greatly appreciate your time, and it's so fascinating to get a big picture overview of how the state is looking at the data that we collect and using it in some really interesting ways to help actual patients. And I know I'm going to take some time and look at the cancer control plan myself and take a more in-depth look at all of that. So next up, we have our Q&A session. Give me one moment to share my screen again. We do have some questions that have come in. And if you have any more questions on any of the presentations, feel free to put them in the Q&A chat. And if we can't get to them during this time, then we will make sure that we include them in the Q&A document that we are sending out after the webinars. And I believe that all of our presenters have also included their information as well if you want to follow up on any of the presentations that we had today. So I will share my screen, and let me just switch that to the other screen. Okay, and then let me share, and we should be viewing my screen in just a moment.
The link to the plan in the chat.
And while I'm doing that, I just also want to say that I did put the link for the evaluation for today's session in the chat, and Rayanne has also shared the link for the cancer control plan. So you guys can take a look at that. And then please fill out those evaluations. We really do appreciate your feedback. And this evaluation should just be for the presentation that you've heard today. We're trying something new this time and looking at those evaluations after each session. So thank you in advance for filling those out. I'll be sending it out in an email as well in case anybody didn't get a chance to catch that link. So you should have the link for the cancer control plan, and you also should have the link for the evaluation in the chat. Okay, I believe everybody should be able to see my screen again. And the first question, I believe this is for Georgia's presentation, based on looking ahead to trying to get cancer data submitted within 1 year. There's somebody who is asking and hoping that there will be access to more AI solutions to collecting some of those data fields. So Georgia, if you want to speak to anything that you've heard related to AI and how it impacts that future goal of getting data submitted within a year.
I think they're working on those issues nationally with various committees. So I think for sure, stay tuned. I know they are, at least CDC is working on, cloud-based platform that providers, that a lot of data will go through there for providers and clinics, and that will eventually come down to each of the states for in terms of where that case belongs. I have not heard specifically about AI uploading, but I think they are developing tools that will assist us in the future for quicker access to information.
Thank you. Next question is related, but what are the CDC's thoughts on treatment plans that extend over a year's time? And I believe this also goes back to the idea of submitting cases within a year of diagnosis or being first seen at that hospital.
So, Candy, you're probably not going to like my response. And this is a definite problem. Because the question I've been asked is, should you hold on to the case if it extends out beyond the regulation, so that you report the case one time and we get complete information? And that's kind of what we struggle with. I would instruct registries to submit the case on time, And that's one of the purposes of critical data changes, is that we share information with you through these formats, and we want you to share that treatment information through a critical data change. I know it's not the best solution. We don't like it, you don't like it, but it's kind of the best that we've got right now. We're looking at how we could seamlessly exchange files in order to update both your system and our system. But I think we've run into issues with that. And does every vendor have that capability? Probably not. So it's definitely on our plate to take a look at. But what we have now in place are those critical data changes. And I don't know if the rest of the team wants to chime in here. So feel free to add anything you want to our response.
I think that covers it. We do continue to receive those critical data changes, and Rayanne and her team process those as you send them in. And one of the reasons that's so important is when we merge the cases here at the central level and we try to match and identify those cases, those critical data changes help us to do that, because that will allow Rocky Mountain to find those matched cases if we've updated the information. And so we do need that back from you guys when you have a critical data change.
So I'm going to answer a quick question from Candy, because she put it in the chat. How are the software vendors doing with version 24? So we've not had problems migrating to version 24. I believe your software vendor is probably the only vendor that has not transitioned to V24. And Rayanne can correct me if I'm wrong.
No, that's correct.
That's correct.
Okay.
Next question, and this looks like it's for either Georgia or Michelle. It goes back to, are there any plans to provide expiration information back to facilities for their registries? I know we do death clearance and everything else. Is there any opportunity to share de-identified shared treatment information from physicians' offices or hospitals to reporting facilities for the completeness of data?
So Rose, we used to do this years and years ago, where we'd automatically send what I think we'd call it an auto update, where we'd send back to hospitals so that they can update their records on any new information that we may have entered on their cases related to death, their vital status, and treatment information. That was back in the old days when most hospital systems had Rocky Mountain. Unfortunately, that's not the case now. So again, we don't know if vendors can handle an auto update, but we have periodically created a file that we've sent back to hospitals to help update their database with death information as well as treatment information. So moving forward, we can still do those special requests, but I don't think, I think nationally they are looking at the possibility of what they're calling M records to update systems at both ends. The problem with M records is that every state wants a different trigger item in order to send that file. And so they're trying to come up with some kind of consensus nationally. And I think it's going to be a work in progress. I think it's going to take longer than a year to develop standards so that we can all decide, oh, what do we want on your end to trigger that M record that comes to us? And then with our vendor is how do we update our record without overriding some valid QA that we've already done on that case. And so there's a lot of issues to work out related to exchanging information, but we still can provide you with a what I call a follow-up file to update vital status information. As we merge cases, we should be sending you treatment information. If we've added treatment information to a record that has been merged with another hospital system, we should be updating you with those critical data changes. So I think that's, I've answered your question. Anybody else want to add anything to that?
I think that covers it.
Okay.
Next question, in terms of checking in with facilities, and I think this is related to that performance measure that you included in your presentation. Does that number allow you to include the facilities that provide a monthly status report back to the ACR?
Yay, I can count it. Yes, I can count it, and I do. So I know Tracy recently asked me about those monthly progress reports. And so Tracy, this is kind of one of those things where we're looking at how do we continue to communicate with every facility, whether they're delinquent or not delinquent, in terms of reporting. And so you've done great. You've mastered those monthly progress reports, so that's great. And your team is doing wonderful.
Excellent. Can staffing recommendations also be sent to hospital administration? And we will never be able to stay on top of reporting requirements without staffing. And we get this question quite a bit too.
Yeah, we do get that question a lot. And Melanie, I think she asks me this question every year. And I struggle with this because I kind of follow the National Cancer Registrars Association, and I don't know that they've updated their staffing manual lately, but I always refer back to NCRA and whatever guidelines they have out there. Unfortunately, at the state level, we can't provide you specific guidelines, but I think what's going to help in this next year is the objective that we developed for the cancer plan, and having to work with these outside stakeholders like the policy work group. I'm going to recommend a lot of transparency. And so what that means to me is I don't have a problem, and nothing prevents us from currently doing this. But if we were to create, and we've kind of talked about, we want to create some kind of kudos to hospitals that are doing great. And but we also want to be transparent in who's delinquent. And so I don't have a problem sharing names of hospitals that are delinquent, but again, I'd have to get upper management approval for doing this. And so I'm definitely pushing for transparency. So, and I think that transparency will help hospital registries in the long run to get more staff if needed, etc. So Melanie, I hope I've addressed your question.
Thanks, Georgia. I think this next question goes to Dana. Do we know how many hospitals are located in Mojave County?
So that is something that I can follow up with in the QA document at the end of the sessions, because I don't have that number off the top of my head, but
I can tell her.
Oh, thank you, Georgia. Yeah.
We've got in Mojave County, we've got Western Arizona Regional Medical Center, and we have Kingman Regional Medical Center, and we have Valley View Medical Center. So we've got 3 facilities in that location. I saw the question ahead of time and looked it up.
I appreciate it.
And not that I have it memorized.
Does the epidemiology data look at a patient that moves from another state who is diagnosed in Arizona because they moved to Arizona for quality of life? We know people are moving from California, for example, to move to Arizona. Do you know years of residency in our cancer patients?
So unfortunately, that is not information we collect. We collect resident at diagnosis, and that's it. And so yes, and that's kind of one of the big limitations of our data, especially when we're asked about cancer concerns in certain neighborhoods, is that we don't have that history, residential history. So yeah, that is definitely a limitation of the data we collect.
What are we as the ACR doing to get software vendors to provide the current layout in a timely manner to hospital facilities?
I think most software vendors are really good. We know that they are asking us for information a lot earlier than usual. Like, for example, they wanted the edits version 2025 by October. And so Michelle has to stop and drop what she's working on to create that edit meta file. So I kind of find it humorous because they want stuff from us early, but yet are not providing the software early for our facilities. I've really only heard about the one vendor in terms of timely reporting. And nationally, I know they're aware of it. We bring it to their attention, but there's not much we can do other than, you know, you're paying a lot for that software. So the question is, what can you leverage to make them faster, since you're paying for the product? So yeah, so it is an issue, and we continue to bring it up nationally. So we're hoping that there is pressure coming from the national folks to this particular software vendor.
And I would also add and just encourage all of you to develop a relationship with your software vendors. I know we have made some attempts to reach out to them to get some documentation to help you with some of the processes that you do when transmitting your data to us. And mostly the response has been that it has to be the user reaching out to them, and that they all do have IT support and help available for you and user guides and everything else. But it has to come from you as the facility that's paying for that software to reach out to them. So I would say if you don't have a good relationship with your software vendor, it's a great time to work on that relationship, and that will be helpful when all these changes happen and you need to figure out how to do new processes with your software. And then just keep communicating with us when you're having software issues, when the software isn't updated in a timely fashion, and we will continue to track what's going on and help where we can. Anything else you'd add, Georgia?
No, you got it.
The next question is something that I can definitely relate to. This person is having issues getting social security numbers. Are there any new websites available to get a death date other than obituaries? And I know it's a struggle. A lot of times hospital registration is no longer collecting social security numbers. Social security numbers are no longer tied to Medicare numbers. And it's a challenge nationally to collect that information. I don't know of any other good resources. And I'm looking at a bunch of head shaking around the table. So I don't.
Yeah, I think I'll throw in my 2 cents. Social Security is becoming more and more difficult to collect. I would encourage, sometimes registrars don't have access to that information because it's hidden within your own system. But I think in that situation, you need to dive deeper and make sure that your facility is not collecting that information. Because I know with hospital discharge, as an example, we have another program that collects these files from hospitals, and we call it hospital discharge. And with that comes a requirement, they have to submit Social Security. But I also have talked to that program, and they have told me that they're having, it's getting more and more difficult to collect that information. And that information is so key to having, for the work that we do in terms of matching and linking. So I would definitely suggest that if you haven't talked internally to your IT, just verify that they're not collecting that information if you don't see it. But also, we have made available a limited CDC SSDI availability where you can do individual searches, but I don't think that they provide Social Security number in this program for us. So if you don't have access to that, and it's been a while since I've looked at it, shoot Juliet an email, and we'll make sure that you at least have access to the system to do searches.
Absolutely. I do have one comment in the Q&A that there's a facility that gets their social security information from billing. So it's possible that if you talk to your billing department, they might be collecting it somewhere else in the medical record. So maybe that's another option to look into. But it's definitely a challenge for sure. Next question, has the ACR looked at the cases that we have to report when there is active cancer, but it's not under treatment at our facility? If we are to report those cases, what is the data used for? These are mostly class of case 32 and add a lot of cases. So we do have information available on our website if you haven't looked there yet, and that's from, I think, 2 years ago, about which classes of case that are non-analytic are required. Those requirements have not changed. I would encourage you to look at what we require. And Georgia, if you want to speak to the value of those class of case 32s, I think that would be helpful.
I don't see the question. That's why I was trying to listen to the question. So the value of class of case 32s is, so these are the non-analytic cases that you're required to report. When you look at it from the state perspective, these are not what we would call non-analytic cases because they are still counted. They are still an incidence case for Arizona. And so we don't look at it when we count our cases. We don't look at it by non-analytic, analytic. So it's very different from the state perspective. We can use the case, we can count the case, and it is counted as incidents. And so that's why they're valuable to us, because if we're looking at the true Arizona cancer burden, they are counted in that in Arizona's cancer burden.
Thank you.
Mm-hmm.
That makes sense. This is the last question that I see, which is, speaking of the metafiles, the ACR used to have an edit related to the address looking at state and zip code compatibility. It was removed years ago. Can it be, or has it been reinstated for 2025 edits? And Michelle, I don't know if you've looked at that yet, or if...
I don't know what that edit is, but I can look and see if there is one.
Okay, so Michelle can look into that, and we will hopefully have more information on the Q&A document after session 4. Just a couple of other comments on the Social Security issue. One person notes that patients are refusing to provide their Social Security number more and more. And also there's a comment that the Social Security file that we send back, or the Social Security index that we let them search individually by, I'm not quite sure which, but that it's not necessarily easy to use as it can't be organized by patient name.
There's a question at 12:02 p.m. that was skipped.
Oh, thank you, Ryan. Let me scroll back up and see if I can catch it. Oh, is this the one about the manual
Yes,
process?
it is, yes.
So this question is, so everything is still a manual process with respect to death and or treatment information updates. And we've got a couple of people thanking us for answers as well. Yes, in terms of the critical data change forms, at this point, they are still manual updates. We will send you critical data changes that we get. You guys are to send us critical data changes when you have updated information at the facility. And if you're not familiar with which fields need to be included on a critical data change, then that is available through our website as well. We have a document that walks you through what is required. A couple of people have thanked us for the class of case 32s. There's a question about, for those class of case 32s, can we make the info a lot simpler to report with only a few fields instead of no information for all the fields that we normally have to report? So, Georgia, I'm not sure if you want to field that in terms of a minimal data set and where we're at this point.
Yeah, I've been asked that question a lot. And I think I need to, because we have certain fields that are required for CDC, we'd still need a complete record. But it doesn't, from time to time, I kind of consult with other states to see what they're doing and how they're handling these things. And I know there's a couple states that have instituted these minimum data sets. But I'm wondering how, when they've done this, how this has affected their overall data. And when they're evaluated for certification, how does it impact those specific fields? And so I think those are conversations to be had at the national level for sure, because we've had this complaint, not just from our state, we've had this discussion from other states as well. Because I know, coming from a hospital background, you really don't, I would say it's about half and half. Some cases you really have great information, and some non-analytic cases you really don't have anything, and you're kind of guessing at when the date of diagnosis is and how that patient was treated. So I understand and I feel your pain, and it would make your reporting process a lot simpler if it were minimum data items. I understand that. So it's something that it's still on our plate, we're looking at, but as I look through the big lens of what we required to report for CDC, I don't know how we could do that and it not affect the data we collect. And so, no, that's still an issue to be further talked about. Yeah.
Thank you for that, Georgia.
So can I add something else? Because I know we've talked recently a lot about critical data changes and how it affects both your end and our end. And I really, so when we get to the point of sending follow-up files again, for example, if we change a case and we've changed that sequence from a 00 to a 01, we've sent you a critical data change and we've asked you to change it to sequence 01. And you do follow up on that case. You get date last contact updated, vital status updated, all of that. And you send us this follow-up file. What happens on our end, if you don't do that critical data change on your end, then it does not match to the case. And so therefore it doesn't update date last seen information. And so eventually, if we start looking at the follow-up rate and what your follow-up rate is, and remember, we follow the American College of Surgeons when they talk about what your follow-up rates should be, 80 and 90%. If we start looking at follow-up rate and your rate is below that, then that's another form of delinquency. And we would eventually get to that. We've never really focused on follow-up, but eventually we're going to get there because we need to. So that's how it's going to affect your follow-up rate. If you don't do those changes we've requested, or if we don't do the changes you've requested us to do on your case. So, and that's where critical data changes, especially related to sequences, name changes, dates of birth, all of those key demographic parts that we link against are critical. So I just wanted to say that about critical data changes.
Thank you, Georgia. So that is all the time that we have for today. Anything we didn't get to will be covered in the Q&A document. Just a reminder to please fill out those evaluations, and that we will not be meeting next week, but that we will have our next session on October 3rd. And thank you all very much. Have a great rest of your day.
Thank you, everyone. Bye.